Good morning to everyone else on the line. This is Carly Houchin at the Kansas Health Institute. You should all be seeing on my screen our agenda for the meeting today. We will get started in just a few minutes at 11 o'clock, but wanted to be sure to let everyone know that our live stream is now running. Hi, everyone. This is Carly Houchin at the Kansas Health Institute. Seeing a few more people have hopped on the call. So just want to make sure everyone knows the agenda for our meeting today is what you should be seeing on our screen right now. Our live stream has started and we'll get the meeting underway in just a couple of minutes. Okay, good morning, everyone. This is Carly Houchin from the Kansas Health Institute. I show 11 o'clock, so I think we have a few people still in the process of joining, but we'll go ahead and get us started with this subgroup meeting on telehealth. I can provide an overview of materials and the agenda in just a moment, but first I want to see if either Eileen or Scott is available to read us the statement on open meetings. Scott, I see you on the call. Are you available to give the statement on open meetings? Okay, looks like maybe he had to step away for a second, so we will get to that.
Hey, sorry about that. Good morning, everyone. This is Scott Abbott with the Revisor of Statutes Office. Due to health and safety concerns, members of the public are not in attendance at this meeting of the Telehealth Sub-Group Working Group of the Special Committee on Mental Health Modernization and Reform. The meeting is being conducted by interactive communication, allowing members of the public without cost to listen to the meeting using live stream audio-visual broadcasting on the internet. The live stream link can be reached by visiting YouTube and searching for the Kansas Legislature channel. The agenda and documents for this meeting have been provided by the Kansas Health Institute, and a link to the meeting materials is provided in the description section of the YouTube feed. Each member of the group and staff will state their name and title each time they begin speaking or voting so that they can be readily identified by remote listeners or observers. All participants are required to ensure that microphones, phones, or other electronic devices are muted when not speaking so that the ability of remote listeners or observers to hear the meetings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the subgroup will not recess to a closed or executive meeting. Each motion, if any, will be clearly stated before the group votes, and the chairperson will announce the results of the final votes. And a recording of this meeting will be available on the Kansas Legislature YouTube channel after adjournment of the meeting for members of the public to review.
Very good, thank you. So this is Carly Houchin again with the Kansas Health Institute. Want to thank everyone again for joining this telehealth subgroup meeting. As a reminder, this group has been tasked by the Special Committee on Mental Health Modernization and Reform to pull together a 10-year strategic plan for modernizing the behavioral health system in our state. Our meeting today, as the title suggests, is about telehealth. And thinking of this as a cross-cutting issue, the Special Committee thought it would be important to have representatives from each of the 3 working groups weigh in on the discussion. So who we have on the line today is members from the Finance and Sustainability Working Group, the Policy and Treatment Working Group, the System Capacity and Transformation Working Group, as well as a handful of supplemental experts who have been invited to weigh in on this topic of telehealth. So our primary goal for our meeting today will be to brainstorm as many ideas as possible about what changes need to or what recommendations the group would like to make regarding telehealth to the Special Committee. So at the highest level, that's what we are aiming to do today. Just to direct you to the agenda on the screen, we will get started with working group member introductions in just a moment, so everyone knows who's on the line. I'll give working group members this quick heads up that I'll have you introduce yourself, and I'll also maybe just have you say one quick thing about what your vision would be for telehealth and a modernized behavioral health system. So encourage you to keep those pithy there, but would be interested to hear from everyone just so we can have a little bit of that big picture in mind as well as we get into recommendation brainstorming. From there, on our agenda, we will hear from the supplemental experts who have engaged with a number of people around the state to gather information related to telehealth. So each of them will introduce themselves and share a little bit about the expertise and experience that they bring to this topic. But then we'll also share their perspective on the issue of telehealth from the particular place or setting in the state where they are coming from, and share as well any recommendations that they have for this group to consider. So we'll hear from each of those supplemental experts one at a time, and we'll ask questions and try to pull out the recommendations that we're hearing there. And then our subsequent agenda item will be a review of telehealth barriers. This was one of the documents that was sent out in advance of our call today. But working group members, if you'll recall at I believe the first meetings when the working groups came together, we went topic by topic and brainstormed some of the barriers that we felt our recommendations should address. So what we'll do is we'll revisit those barriers that had been brainstormed related to telehealth to hopefully kind of cross-check that with where we are in the discussion at that point to see if there's new recommendations beyond those that kind of come out of the discussion with supplemental experts that we would like to make note of during our brainstorm. Then we'll try and at 12:25 move to a few quick administrative update items so we can keep everyone in the loop as to where this group, where the work of this group is going, and then we will adjourn by 12:30. Want to quickly remind everyone of the meeting commitments that the working groups have made. Those are at the bottom of the agenda there, but we're committing to come ready to both discuss and compromise. We're going to work to keep our remarks succinct and on topic. We're going to ask questions when we have them, and we will start and end on time. And to that end, that might require me to put time boundaries around some of our discussions here, but really encourage everyone to weigh in as promptly as possible. We have a lot to get through today. So with that, I will stop my screen share here so that we can run through some introductions of working group members. So I think probably the most efficient way will be to kind of call on everyone individually and would ask working group members just to very quickly introduce yourselves similarly to we do on each of our meetings. But if you could also at this point say kind of that one thing about your vision for what telehealth looks like in a modernized behavioral health system. So with that, I will pick on, sorry, Dr. Warrens, you're the first one showing up on my screen if you'd like to kick us off.
Hi, Will Warrens, behavioral health medical director for Sunflower, Kids TLC in Olathe, and also the Guidance Center up in Atchison, Leavenworth, and Jefferson counties. And I guess my statement on telehealth would be hoping to see an increase in not only the volume, but also the sophistication with which we're able to use telehealth, over the next 10 years.
Very good. And next I see Gary.
This is Gary Hinnon, Behavioral Health Director for Youth Services, KDADS, and I'm part of the Policy and Treatment Subcommittee. My thought about telehealth is I think it could play a very major role in providing greater access for services, but should not take the place of that one-to-one service, but be an adjunct to that in addition. So and making those services more available to people in all areas of Kansas and under all circumstances.
Very good. And Rennie?
Hi, Rennie Schuler-McKinney with Advent Health Shawnee Mission, part of the Policy and Treatment Group. And I would love to see the state line barrier to be broke down for a resident of Kansas who happens to be out of state to be able to access their therapist.
Very good. And Kyle?
Morning, I'm Kyle Kessler with the Association of Community Mental Health Centers. I would like to see us be able to keep the quality of care for behavioral health at the same level and be able to continue the current telehealth practices without compromising care or payment, especially as it relates to Medicaid.
Very good. And Sandra?
Hi, this is Sandra Berg with United Healthcare. I'm the Behavioral Health Director here. What I'd like to see is accessibility for our folks across the state to access services and not have barriers like the originating site that we currently have to improve their access, but also keep it appropriate to developmental and just that one-to-one touch is still important. So that's my vision.
Very good. And Sunny?
Hi, my name is Sunny Mcclendon. I'm the Vice President of Government Community Relations for Blue Cross and Blue Shield of Kansas. I'm also a member of the Policy and Treatment Working Group. And I would really like to see consistent standards that are available for patients as they're using telehealth with behavioral health needs so that we can ensure they're getting the same quality care, whether they're in person or using the services via telehealth. Thank you.
And Denise.
Hi, everyone. I'm Denise Sisman from Community Care Network of Kansas. And some of what I envision has been said before or already, but I'm envisioning that telehealth will increase access to behavioral health while at the same time ensuring quality of care and health outcomes that remain equal to what one would have through a face-to-face visit.
Representative Landwehr?
Brenda Landwehr, state rep out of Wichita, and mine would be to clarify who and how and who uses it, and to include or increase access, as well as helping to combine the integrated care issues we've spoke about.
Very good. And next I see Lisa.
Hi, I'm Lisa Southern, Executive Director at Compass Behavioral Health. I agree with all of what's already been said. Just want to make sure that this access can continue at least in some capacity. We have found in this that there's a lot of people who wanted services who could not get to them. And so we want that to continue for them.
Very good. And Greg?
Yes, Greg Hinnon with 4 County Mental Health Center. My vision would be really in our frontier counties that there be broadband access, that there be an infrastructure that would allow this to be utilized, because so many of them have a long distance to travel. This has been a great way for them to access care.
And Rachel?
Morning. My name is Rachel Marsh. I'm the CEO of the Children's Alliance of Kansas, and I'm on the Policy and Treatment Working Group. When I think about a modernized vision from where I sit, I think about the most vulnerable populations in Kansas, and the homeless population, the population with unstable housing, the population who may be uninsured and not having availability of a primary care physician, and the barriers that our current system has about when you move out of a certain catchment area or a certain city, you lose your therapeutic relationship. So my vision is that we can allow better timely access for those people who may otherwise not be able to develop a relationship with a provider and then continue the consistency with those providers.
Very good. And Representative Bishop. Are you able to unmute Representative Bishop? Looks like she might have stepped away for a moment. I think that takes us through the working group members on the call, but I'll pause there in case I'm missing someone. Any regular working group members who I've missed in those initial introductions there?
I don't know if it's appropriate, but I'll say that this is Fran Seymour Hunter from KDHE, substituting for Sarah Fertig, who had obligations she could not get out of.
Thank you, Fran. My apologies there. I missed you on the list there. Any comments you would like to make around a vision for modernized approach to telehealth?
The only thing I would add, because I pretty much agree with what everyone has said, the only thing I would additionally add is that we need to keep close track of how, since I work for the Medicaid division, whether they pull any of this back and make sure that we adhere to any restrictions that they may impose in the future, but try to press the envelope just as much as we can, as long as we can assure quality and choice for the people that we serve.
Very good, thank you. And I'll circle back one more time to see Representative Bishop. Are you able to introduce yourself?
Certainly. I'm Representative Elizabeth Bishop from District 88 in Southeast Wichita, and I'm primarily here to learn.
Very good, thank you. So thank you to working group members for sharing those thoughts with us around vision. Those of you who have participated in some of the special committee meeting will kind of see that as a recurring topic. In our working group product that you'll see in the coming weeks, we are attempting to capture some of these thoughts in vision or guiding statements around each of the 10 topics that have been assigned out to each of the groups. With that, I'll move on to our supplemental experts. And what I will invite each of our supplemental experts to do is we'll go one by one. I'd invite you again to introduce yourself, tell the group a little bit about some of the expertise that you are bringing to this discussion. And then a number of you provided an overview of some of your thoughts related to this topic. So I'd invite you to spend up to 10 or so minutes providing the group with an overview of the information that you've provided. And if you could give particular emphasis to any recommendations that are coming to mind to you, group, I'll flag, this is of the 10 topics we've been assigned, this is the one that we don't have any recommendations from those previous 5 reports as a starting point. So really our aim today is to pull as many recommendations out of this discussion as possible, so we have a good batch to move into prioritization with in our meeting on Friday. So with that, Shauna Wright, have your name at the top of my list here. If you would like to introduce yourself and share a little bit about the materials that you submitted.
Absolutely. Good morning. It's nice to see you all today. As a quick background on myself, I'm a licensed psychologist. I started my professional career in Southeast Kansas with community mental health, with a strong passion of serving rural and underserved populations. About a decade ago, I started an independent practice where I solely telepsychology into skilled nursing facilities throughout the state of Kansas, again, into rural and frontier communities. For the last 5 years, I've worked with KU Center for Telemedicine. I'm the associate director there, where we really look at innovation, policy, research, and how we can push and support telehealth. This last year, we've been primarily focused on assisting healthcare and behavioral health agencies learn about telehealth and stand it up in an ethical and data-driven manner. I'm also the chair of the Rural and Frontier Subcommittee for the Governor's Behavioral Health Services Planning Council. So the recommendations that I share today are really under that umbrella, where our vision for telehealth is behavioral health equity. And the Rural and Frontier Subcommittee has been focused on telehealth as an area of growth and expansion and research for our rural and frontier partners for more than a decade as well. They started studying telehealth and looking at how telehealth could be adopted as a means of increasing behavioral health equity in the state. And we've been pushing that for a long time. So the recommendations that I share today with you are under that umbrella. I am not speaking with these recommendations through the KU Medical Center or KU Telemed Center. However, my training and support there does inform ways that we can do this in a manner that is most appropriate for organizations, consumers, and providers alike. But I would like to share some of our recommendations and what our subcommittee has learned through our partnerships with rural healthcare providers, and primarily in relationship with our community mental health centers and the data that they've shared with us in informal ways. So with our vision of being behavioral health equity, we of course want any telebehavioral health services to be in line and sufficient to say that we're delivering the same standard of care telehealth as we would in person. And we also believe that consumers should have a choice. Right now, under the umbrella of the pandemic, there are fewer choices when it comes to keeping our consumers and our clients safe, and of course maintaining the health and well-being of our workforce. However, in terms of making sure that we are able to deliver appropriate healthcare, to the right person at the right time in the right place, these are some of the recommendations that we have. And many of these recommendations are also informed by, of course, the data that we've received from community mental health centers across the state. We want to really encourage and recommend that telehealth, telebehavioral health codes remain in place for telehealth beyond the pandemic. We know that those were Medicaid approved prior to the pandemic. Some of the things that have changed, of course, are the originating site. So we recommend an adoption of originating site consistent with the Kansas Telemedicine Act, which broadly defines it as the location of the patient at the time of the healthcare service and when that's delivered. So this would be inclusive of sites such as a place of employment, a home, a school, so that we can meet the patients where they need to be met. But we would want to, put some parameters around that to make sure that we're following safety standards, HIPAA standards, and that the client has the privacy protection that they need. We'd also want to make sure that organizations are educated about how to guide that process with their clients to make sure that telehealth is never delivered in an unsafe fashion. For instance, if someone is in a moving vehicle or in a public setting or using free open Wi-Fi or broadband. So we would put some parameters around that, but we strongly recommend that we are able to continue to reach into the consumer home if our workforce and our healthcare organizations can receive the training and policy guidance to make sure that can happen in a safe manner. Right now, we are very aware of the broadband deficiencies across the state. And even though we prefer televideo, telebehavioral health as a means of approximating that in-person care, we are very sensitive to the fact that many of our consumers do not have access to broadband. I think someone earlier said that he really recommended that we continue to increase broadband access and build up those networks. We do too. But we know right now we have consumers, particularly in our frontier areas, that do not have that access. And we want them to have access to telebehavioral health through the phone. Again, we put a supplement or some extra guidance on that we want our providers to understand how to deliver that service. But we don't believe that they should be excluded from access to telebehavioral health just based on the fact that they don't have broadband. So that's a strong recommendation for us as well. We understand that when we shift to telehealth billing, that our facilities may lose some of what they capture through reimbursement, because the telehealth fee is generally a fee for service and does not include facility fees. And when we're reaching into the home, we recommend that we explore those reimbursement options for facilities so that they're not losing revenue by delivering telehealth into the home. We know that to adequately support telehealth, we pay a technology fee, and our IT staff are under a huge burden right now. So we want to consider how we can assist facilities in maintaining a telehealth line of service without losing revenue that would impede their organization or their ability to continue to deliver services. Let's see, we strongly recommend that if we're able to broaden out reimbursement for telehealth services, that we provide some guidance to organizations and providers about developing telehealth policy. And through doing that, then we're capturing different areas that would help maintain that high quality of care, where we're looking at administrative issues, clinical training issues, technology issues, to make sure that organizations that maintain an open line of telehealth service have really kind of stepped into the telehealth waters and understand all of those elements, how they come together, and how they support effective and sustainable telehealth. And then, we have a set of recommendations for providers where we want them to have access to training to help them understand the nuances of telebehavioral health. This does not have to be an extensive training, but enough to where they are recognizing some of the nuances and making sure that they know how to assess and determine when they may need to shift to in-person, and that not everything can or should be done through telehealth. We want to make sure that providers understand our HIPAA guidelines and why connectivity, our internet connectivity standards, are important for providing adequate care. We also recognize the toll that telehealth has placed on our providers, and we want to make sure that they have access to information about self-care and really responding to technology fatigue and Zoom fatigue, because what we're hearing from our partners is that our productivity has increased through telehealth, particularly in the behavioral health field, where we're seeing providers see more and more clients during the day, increasing their paper workload and increasing their screen time. And there's also a toll that comes along with providing care through telehealth. And we want to preserve the workforce. We don't want to transition and build in telehealth and then burn out a workforce that doesn't want to work. So we want to be cognizant to the health and well-being of our providers as well. In the domain of consumers, we want to ensure that if we're providing telehealth, that we're providing consumer education about what telehealth is, what their consumer rights are, how they can interact with providers and organizations if they have preferences of in-person versus telehealth, and that they understand the risks and benefits of telehealth, that we don't just turn them to telehealth and say, this is the only thing that's available to you in your area, but we make sure they understand their options and their rights as they use telehealth. And we probably need to have a means of educating them about telehealth so that they understand why we can't connect with a provider while we're driving down the road or when we might be in a public environment. So that education piece and the consumer informed piece of telehealth is important to our group as well. I know that was quite a mouthful. I covered a lot of domains, but our biggest preference, our strongest recommendation is that we find a way to increase access through telehealth into the consumer home, even by telephone if necessary, for the purpose of behavioral health equity.
Great. This is Carly Houchin again at KHI. Thanks so much for those comments, Shauna. Want to open up the floor to working group members. Any initial questions that you have for Shauna?
This is Sandra Berg with United. One question I do have, Shauna, is around the quality assurance. You touched on it just a little bit, but can you expand on that? What you do for quality assurance in telehealth usage?
Are you thinking more in terms of, I think we can break that down into several different domains. Are you looking, is that question more framed under the umbrella of treatment outcomes, consumer satisfaction, provider engagement, or is it all of the above and then? So quality assurance, I think the strongest recommendation and the wheelhouse we get there is really encouraging sites that are going to deploy and keep a telehealth line of service open into adopting a telehealth policy, right? Not just saying we had to step into this because of the pandemic and we're doing the best that we can. We know that that's happening, but if they're going to maintain telehealth as a line of service, that we give them some guidance in developing telehealth policy, which includes ongoing quality improvement, ongoing measures, ongoing consumer feedback. And we may not have to dictate to them exactly what their telehealth policy is, but actually tell them, we need you to have a policy that tells us what the elements of your program are and how you're meeting each of these needs. Because training of our professional staff, the protection of their health and well-being, those are important, but consumer education, consumer rights, and quality improvement in that regard are important. So it's important that we encourage them to set up those policies and give them the domains that we need to know that they've thought this process through in order to maintain a consistent line of service. Did I answer your question, or is there still anything outstanding on that one?
No, you answered it. Thank you very much.
And this is Carly at KHI again. Now working group members, I was trying to take notes there as Shauna was talking, but want to see what recommendations you all heard in there that you would flag as particularly important for additional discussion from this group. So any recommendations you heard in there that you want to be sure we have captured in our list of possible recommendations.
This is Representative Elizabeth Bishop. One of the things that I heard was the need to address the codes in such a way as to capture some of the infrastructure costs for service delivery for an agency, a clinic, etc.
Great, thank you, Representative Bishop. I believe I've made note of that as something along the lines of explore reimbursements for facilities so they're not losing funds on telehealth services delivered.
And that's particularly to the home. I know we have agreements if we're providing telehealth to another site or a supervised site, the site that supports the client or the patient can collect an originating site fee. Those fees are lost, when we're connecting to the home, yet the site that's delivering, the distant site that's delivering the service really invests more than, because supporting a patient and their technology needs in their home is a lot more of a burden on the site that's delivering services, because then they become like an IT support hub right there within their own facilities, and that is costly.
Other working group members, what recommendations do we want to pull out of Shauna's comments there to make sure we have kept?
This is Denise Sisman from Community Care Network. I would support adopting a broad definition of originating sites consistent with the Kansas Telemedicine Act as outlined on this. I think that's very important. Also, the televideo and telephone services for areas that have deficiencies for broadband and or other kinds of barriers for individual consumers accessing the type of equipment needed for anything beyond televideo and telephone.
Thank you, Denise. So I'm just gonna read back what I have written here and make sure that's capturing that. We want to recommend or consider recommending an adoption of a broad definition of originating site consistent with the Kansas Telemedicine Act. Seeing general nodding there. Okay. And then the other one was we wanted to increase access to telehealth in the consumer home utilizing telephonic means when needed. Any edit there, Denise?
No, I think that's good.
Great. Okay, one more call, working group members, other recommendations in there that we want to be sure to have pulled out to revisit.
Carly, I guess I kind of have a clarifying question. Are we saying in this that we want to see an originating site fee, a facility fee, and a technology fee mandated? And then are we looking at Medicaid and insurance companies to pay for the technologies for people at their homes?
Working group members, care to clarify what all we would like our recommendation to encompass in regard to Representative Landwehr's question?
This is Kyle Kessler. And I think that last item first, I don't know that I had expected or considered having insurance companies or Medicaid MCOs pay for the technology. I think there is some of that occurring now, but things like telehealth, I mean, I think mandates are a little bit tricky in how they can, whether it's through CMS or private industry. So I don't know that I had thought about that as being a specific recommendation from this group. In terms of fees associated, I think just looking at the rates and rate equity as it relates to managed care is probably the simplest, cleanest way to do it. But if others feel differently, I'm certainly open.
And Kyle, can I comment on that?
Please.
Good morning. So what we're looking at is maybe an adoption of what happened during the pandemic. So we already know that Medicare and Medicaid already have mechanisms for telehealth billing and originating site reimbursement. What happened during the pandemic is, and I don't know how familiar you are with telehealth billing. I'll give a real quick crash course. Prior to the pandemic, we had agreed that O2 was the place of service for anything telehealth. And what happened when you billed place of service as O2 or telehealth was you were reimbursed the provider fee, right? And then if the originating site wanted to bill, they could collect the originating site fee. However, when we started using that code through the pandemic, our facilities were saying we're losing our facility fees because if a mental health center bills as a 95 or whatever their code is, they get the provider fee in addition to the facility fee, the support staff that goes into that. So an easy resolution to that might be that we go back to, if we're delivering services to the home, that we continue to collect our facility fee and use our facility as the place of service, and use a modifier like the GT modifier we've been using before. Somehow we'd have to identify that we're still reaching into the home, but that would allow us to, well, the GT, we would have to figure out a mechanism to recognize that the reason we're maintaining the facility fee is that our facility is supporting the technology to the home, if that makes sense. If we go back to our standard protocols for telehealth billing after the pandemic, we would go back to that O2 as place of service, and our organizations would miss out on the facility fee, which captures the support staff, the rooming, all of the things that go along with that organization's support of the patient.
I guess, Carly, as we proceed on this conversation, is that we have to have clear lines of prior COVID and in COVID, because those are two different topics. The money's totally different. The reimbursements that's coming in from the federal government's not going to be there forever. And we could end up, crashing this system, destroying the system, making it too expensive for us to do. So whenever we're talking about, you know, how we're going to pay for this and how people can bill, is that we clarify that I don't believe that we should operate under current COVID financing, that we operate under pre-COVID financing.
Okay, this is Carly at KHI. Thank you everyone for those comments. I'll maybe make one last call for recommendations that we should be sure to highlight here. Then in the interest of time, we'll move on to our next supplemental expert.
Carly, this is Sandra with United, and I'm going to go back to the quality assurance. And I think everything that Shauna has put in here under organizations, providers, and consumers around education, the quality of services. I don't know how to summarize all that, but I think we need to pull that piece in as well into our recommendation.
Okay. We'll take a look at that and have some maybe some cleaned up language to propose for the group whenever you're scoring and prioritizing in our next meeting. Okay, thank you, Shauna, for those comments. Very helpful discussion here. I believe the next supplemental expert that I have listed, if he's ready, would be Shane Hudson.
Yeah, thank you, Carly. My name is Shane Hudson. I'm the CEO at CKF Addiction Treatment, where I've been the CEO for 10 years. I'm a licensed clinical psychotherapist. I'm a licensed clinical addiction counselor. I have a master's degree in clinical psychology, and I just completed a master's last year in healthcare transformation from UT Austin, which really focuses on value and bringing equity to the healthcare system, and, you know, creating a better structure for how we deliver care and how we get reimbursed for care across the board, not just behavioral health and addiction services. I'll make a quick comment because I think Shauna, I've worked with her, I don't know, over the last 3 years a lot. I've been involved with Project Echoes and other things that we've done together, and she presented a very good itemized list. I agree with all those things. The question about assuring quality, I will say that our staff are getting more frequent direct supervision than they've ever gotten because we have telehealth capabilities in place, and our supervisors can connect with them right away in their homes and be there more frequently than when we had to travel from Salina to Junction City, from Salina to Abilene, from Salina to McPherson, maybe see them in person once a month. So that's been a very good thing for our group supervision and our individual supervision to ensure that what's happening there with supervision is of quality and effectiveness, but also being able to sit in on sessions as they occur. And of course, with the patient's permission and knowing that the supervisor is going to sit in on this group session or this individual session, that's a very good way to monitor what's happening in a way that we'd never seen before. I never had a supervisor after I was, you know, done with all of my requirements for my license, come to Junction City and sit with me while I delivered care. Who knows what's happening in those offices in rural places that are far away from where you operate with the majority of your staff. So I'm not saying horrible things, but I'm just saying you're not there to see what's happening. And this has created a good, efficient avenue for us to monitor some of those things. So that's been a really good thing from our perspective. So to move on to what I've seen, this really, of course, as you all know, isn't a COVID issue. This isn't even like telehealth, the end all be all. This is about equity. This is about access to care and also supporting patient outcomes. There's a lot of work to be done in healthcare around those things. This is one thing and a list of possible solutions that's really going to help. CKF Addiction Treatment will never have a physical facility in every town. Every town will never have in-person addiction treatment services to the extent that they really need to occur, such as intensive group services. I'm not talking about if you could, which it's even not going to happen in this way, but you had an expert in each town who's in person, who's duly licensed, who does some individual sessions for addiction. That's not good enough. That's not good enough for our patients. That's not the most evidence-based care, and we need more intensive services than that. You're not going to have all these things in person physically. And with addiction healthcare, we know that 1 in 10 Americans age 12 and older could be diagnosed with a substance use disorder. We also know that only 1 in 10 of those individuals are actually accessing treatment services. We know 2/3 of the people who are those 1 in 10 of 1 in 10, those 2/3 in treatment settings are referred by criminal justice primarily with some self-referrals. And we know that that 1 in 10 of 1 in 10 that are in treatment settings, 6% were referred by another healthcare provider. So I would say in our current system with in-person services, it's just not cutting it. Not to mention how we treat addiction as a chronic illness and need more long-term follow-up care, but the focus on outcomes versus volume So look at what's working now for in-person services, look at what's not working, make adjustments as we go along, and figure out how to apply these things with technological solutions to align with those things that are important to us. Everything needs to be moved better on that scale, and telehealth is no different. Let's bring it along and not forget about it. So in the realm of telehealth, we started providing telehealth support services to opioid grant patients 3 years ago. I think we're in our 4th year of the grant now. So we received federal funding through our agency to cover 65 counties, so Western Kansas. As I was doing presentations to communities in Western Kansas, I really got this focus on rural and frontier communities. But when I say that, I'm also now going to apply it to access in urban areas, because not everyone can take time off of work or ride the bus or have a car or have gas or have childcare, ... to get across town to the service they need, and depending how large the town or the city is. So even then, you may as well be in rural or frontier Kansas without anything nearby, even though treatment and healthcare is saying, hey, we're over here, just come get to us tomorrow at 3. That person may not be able to do that. So when we were going out to communities and presenting about our grant and getting access to patients, there are plenty of places saying, well, that all sounds nice, but you don't have anything out here for us, or the patients weren't getting access for dollars to even flow to them to get them services. We started support groups via telehealth. And through that, we recognized some things. A, I can activate a lot more staff across the state with these types of services, because if a staff, this would be a recommendation on my end when we talk about service site, et cetera, origination. There's another component to that. Staff in the workforce crisis, we have a lot of staff across the state. They may not live close enough to a treatment center or a mental health center or fill in the blank to do a lot of good. We do have staff who work from home, who have home offices, and we pay for their internet and their computer, and they're one of our staff, and their office isn't down the hall. It's 3 towns over in their home, and they've, of course, signed all the agreements, and we have policy and procedure behind what that space looks like and confidentiality. But we can access more staff across the state. So if you talk about a workforce crisis and maybe even the number of staff that want to work that can't, you can access those staff if they're able to work from home and deliver a service. You're also able to provide in-person direct supervision via telehealth and sit in on some sessions with those staff. So we actually know a lot more about what's happening in that treatment setting than maybe in the past in one of our outlying offices and what was happening in those spaces. The other thing was that patients who were accessing the service were saying, you know, I've never had access to a service before. This is great. It's helping me in a real way. And I would like to see this continue even if I'm not accessing your service. And we saw that we had a lot of barriers getting paid. So I had to use the grant. The grant was great because patients could sign in from their home, because we had staff who could sign in from their home, because we could create capacity in a way that we weren't able to before by searching and searching and searching for someone who lives close enough to Salina, Kansas to come work for us, and then connect a service to someone who lives even further away from Salina, Kansas, get a service. We didn't have to hire someone in Salina and make people travel 2 hours to come to a service in Salina. So as we went along there, the OUD grant was very helpful in that realm. We were working towards expanding and building these services when COVID started. And the helpful thing that has come along, of course, is the lessening and restrictions of how we can build services and really like, let's help people. True, let's help people. It's not all about telehealth. Telehealth should definitely be an option. I don't see us building in the right direction and achieving, access and also tracking quality outcomes, which I think we need to do a better job of even in our in-person settings, not just in behavioral health, but across the board. So if telehealth isn't at the table, then we're losing an opportunity to provide equitable care. If I'm someone who can call my doctor and they can say, oh, it sounds like you really need a service, I want to help you. How would you like to access this service, and how is it going to work for you to get access? Versus healthcare saying, we're here, you just have to come to us. And if you can, you get healthcare. And if you don't come to us, you don't get healthcare. So how do we make it equitable so that another individual who's not me, who may be lower socioeconomic status, who may not have insurance, who may be a minority, who may live in rural Kansas, frontier Kansas, or even urban Kansas, how do we give them options to access their healthcare and really talk to them about their outcomes from the start and track those longitudinally? In person or telehealth. So as you look at these things, my overall recommendation would be to raise the bar together, aligning telehealth with in-person as another option that's available. And all the recommendations Shauna made were great. And of course, we need to expand broadband access. That's part of that equity piece. Easy for me to say I have my phone and I have a computer and I have a car and I have time off work and I can afford childcare. My son's 15 now. He can watch himself, but That's great for me. How lucky am I that I can address my healthcare? That should be the same for everyone. And I would say that even now, when we talk about the expense of telehealth, how much money is being lost in the system because it gets spent on high cost levels of care over and over and over and over again. You could spend a fraction of that on a patient to get them access. And if they achieve positive health outcomes, they wouldn't be going through the revolving door of the emergency department or residential care or detoxification centers. The other piece of that is, what about, health insurance companies want patients to get better. They'll see those outcomes as well when you talk about dollars. That doesn't mean health insurance companies need to pay for it, but that means if we really care about the people we're serving, we'll figure out a way, because this is one of those solutions that's going to help achieve better healthcare outcomes. Health is happening 365 days a year for each of us. So I would just recommend that we keep our eye on that versus making it all about telehealth or all about COVID.
Very good. Well, this is Carly Houchin at KHI. I want to open up to working groups. I'll put the questions together this time. Any follow-up questions for Shane on the comments shared there, or any recommendations you heard in there that we should be sure to pull out to capture in our notes for further discussion?
This is Denise Sisman from Community Care Network of Kansas, and I would support the recommendation to allow staff who are working from home or even in other non-clinical sites to be able to provide telehealth from those locations.
Great, thank you, Denise. Others?
This is Gary Hinault from KDADS. I think, and I'm not sure, Carly, how we want to put it, but I think we should add something related to the supervision of staff through telehealth.
Yeah, could you say more about that, Gary? As far as
it's been an issue, I think, and I think it's been an issue in several different disciplines in how we're able to. I'm thinking about some of the disciplines that ABA and other things in maybe the rural and frontier areas of Kansas that we're not able to have the appropriate supervision. And if we could do that supervision through telehealth, that I think could be very helpful.
This is Shauna Wright with the Rural and Frontier Subcommittee. May I make a comment on what Gary just said?
Sure.
The behavioral, the BSRB, the Behavioral Regulatory Services Board, they govern all of our mental health professions, from substance abuse counselors to marriage and family therapists to psychologists. And they have different regulations for each profession in terms of the type of supervision they can get and the amount that they need to get their independent license, depending on their profession. The Rural and Frontier Subcommittee has long worked and advocated with the BSRB to equate in-person supervision with telehealth supervision, especially so our rural and frontier communities can really get all of their professionals licensed. And each profession has different regulations. And what they've told us is really to change that, is they need some sort of legislative action saying that in-person supervision is equatable to telehealth supervision or televideo supervision, and then they can work more broadly to adopt those regulations. And that we definitely in the state took a hard hit for those professions that needed in-person supervision during COVID to meet their guidelines and their timelines for completing supervision to get their independent license. So this has been an issue that the Rural and Frontier Subcommittee has advocated. So I appreciate Gary bringing that up, because I think that's just another piece that needs to be addressed to help build our workforce, particularly.
If I may, Shauna, I'm on the advisory committee for the addiction counselors through the BSRB. So we do, through that group, the licensed addiction counselor group, allow telehealth supervision. I can't remember right at the moment if that allows for 100% telehealth or if it's a certain breakdown, but I think I see other licenses coming along. So you talk about like the licensure supervision that's required so you can have that independent license or become licensed in whatever way. And then you have like the functional supervision after someone's licensed and they're done with that piece, that they go ahead and keep getting supervision to serve their patients through their agency. For the functional supervision, there's not something that's saying like you can't do it this way, or this way. It really depends on the agency and what they say is okay and not okay. When you get to the licensure supervision, there's some movement happening there, which is a good thing. And with the addiction counselor group, that's good. And I've heard that there's other licensure groups that are looking towards that being approved as an appropriate way to get your supervision for licensure.
Great, thank you. So this is Carly Houchin at KHI. I'll make one more call. Last comments as far as recommendations to flag from the information that Shane shared, or questions for him. Okay, thank you so much, Shane. Then the next supplemental expert that we will hear from, if he's ready, is I think David Jordan. Might be muted. Let me see if we can.
There we go.
Great.
Perfect. Well, thank you for having me. My name is David Jordan. I'm the president and CEO of the United Methodist Health Ministry Fund. We're a health philanthropy located in Hutchinson, Kansas, and we support 3 strategic program areas, one being access to care, 2 being early childhood development, and 3rd is a healthy congregations program. As part of our work in access to care, we actually convene a group of frontier hospitals in Western Kansas, the Kansas Frontier Community Health Improvement Network, and that also includes mental health providers and primary care FQHCs. And as part of our early childhood work, we support a number of initiatives centered around early childhood mental health. I think why I'm here today, because there's many experts on this call, is just to give some brief background on a research project that we convened and funded. Earlier this year, the Health Fund was interested in learning more about the status of telehealth use, particularly what resulted from policy changes related to the pandemic. So how did the policy changes related from COVID-19 impact the delivery and utilization of telehealth services in Kansas? We worked with the University of Kansas School of Medicine's population health team, Dorothy Hughes. We also partnered with the Heartland Telehealth Institute for some expertise to really pull together provider groups in Kansas to better understand the provider experience related to telehealth. And we did a real snapshot survey of providers in Kansas, partnering with the Community Mental Health Association, the Medical Society, the Hospital Association, Community Care Network, the Behavioral Health Association, family physicians, pediatricians, and the Association of the Osteopaths, to really get a perspective on how they were using telehealth and experiencing it, as well as using them as proxy for consumers. I shared as part of background for this meeting, which was sent out a little bit later, just some of the initial findings. We haven't published this document yet, but will be in the coming weeks. Then we'll follow this research with interviews with the providers, 20 in-depth interviews, and then we're looking at a consumer phase of research. It's important to note that we did get some pretty solid response from the professions. We had 227 providers respond that they are utilizing telehealth services. There were some that responded that weren't, but that was a small percentage, less than 8%. The response was really majority driven by primary care physicians. However, while primary care providers were responding, a number of them were offering behavioral health services, particularly counseling and therapy, psychiatry, and SUD services. So I think it's very pertinent to this discussion. Video conferencing was the most common modality used across settings. However, there was a great benefit of being able to access or provide services through audio or telephone only. Generally, there was a significant increase in telehealth volume from 2019 to 2020, and then a decrease, a small dip or leveling off in the summer and fall. From a policy perspective, respondents really responded that payment policy is critical to the ability to continue to deliver telehealth services. Prior to the COVID-19 changes, providers stated that reimbursement did not cover a large cost, and this was by a large margin of providers in terms of the response. They perceived that insurance coverage of telehealth became much more prevalent from 2019 to 2020, and their perception was that reimbursement across payers improved from 2019 to 2020. Of all the policy changes and next steps identified by the providers, the payment parity was a top priority, and the policy changes put in place as a result of the pandemic were largely characterized as positive. Both from a perception standpoint, there was a perception that both providers and consumers were benefiting from telehealth experience and from these policies. That's not to say that there is not a need to look at better equipping patients to access telehealth services. There was a perception among providers that consumers could use assistance in accessing, infrastructure such as broadband or devices, or better assistance using the devices as part of the telehealth visit. However, largely, there was an overwhelming sense that the large proportion of consumers could access the telehealth services and that it was a benefit to them. Payments, it probably can't be understated just how the enhanced reimbursement made an impact in terms of making telehealth more available and sustainable for the future, and looking at a way to maintain the changes put in place as a result of COVID-19. I think, in light of the technology usage, there could be some exploration, and this is me speaking personally more from individual conversations, use of other team members like community health workers to help consumers better use technology and utilize it. That might be something to consider beyond what's been discussed in terms of looking at maintaining payments that resulted from policy change, as well as some of the language regarding the originating sites. I'm happy to answer questions, and I know that some of the participants in this group, their membership, or they may in fact filled out the study. So I also would defer in some ways to the providers on the call and thank folks for the time and participation.
Great. So this is Carly Houchin at the Kansas Health Institute. Working group members, any questions for David or any recommendations we'd like to be sure to pull out from those comments to for the group to consider further in our next meeting? Okay, not hearing any questions at this point. Thank you, David, for those comments. Very good. Our next supplemental expert, I believe she's still on the line. Dr. Nelson, are you ready to share a bit with the group from your perspective?
Yeah, thanks for the kind invitation to speak with the group today. Kansas was an early leader in telehealth, so it's kind of nice to hear things come full circle and to hear some of the exciting directions you all are looking at for now and 10 years into the future. I just want to start off and mention, we live in such fortunate times that we do have effective assessment and treatment for behavioral health. The idea is, how do we connect those strong evidence-supported treatments with folks in need, with underserved populations, and especially in Kansas, our rural communities. So just kind of reiterating, how do we open that door with the telehealth technologies that we're talking about today? I wear several hats, so I want to talk a little bit about each telehealth hat and then describe perhaps recommendations that I think very much complement what's already been said today. One hat that I wear is the lead for the Heartland Telehealth Resource Center. So we're federally funded and provide nonpartisan technical assistance around telehealth and teleeducation. We've been fortunate to partner with David with the survey that was described. But I think what that group may be able to offer is just really thinking about, not reinventing the wheel, but how do we continue to make it better, supporting practices who may have gotten excited about the technology during COVID and the intense need, and how do they continue to implement telehealth post-pandemic. So I believe some of the recommendations that have already been mentioned around teleeducation, linking with professional guidelines and professional best practices, just sharing that there are many resources I think that could be shared and to help in meeting that excellent goal. Another hat that I wear is I lead several federally funded projects that look at telehealth as a system changer. So using telehealth to be able to connect with schools. We have a large school-based program, using telehealth to be able to connect with rural primary care, and then most recently using telehealth to connect with communities looking at disaster needs, and then really that's changed into meeting some of the pandemic needs. But that's why I've stuck with telehealth for 20 years, is there's much potential really to how do we get care coordination across those groups that are serving children, and how that technology can help us at times, implement some innovative care and really meet the child where they're at. Another hat is I'm a researcher in telehealth, so I lead several large NIH trials right now that are looking at telehealth to the home. So I really appreciate what's been mentioned already about how do we learn from the research and apply some of those lessons, but just the importance of quality improvement and having means to share the lessons that we're all learning about telehealth and as we're implementing. I believe telementoring and ECHO has been mentioned. We lead several telemedicine echoes, which can be a mechanism to do that, as well as some of the ongoing continuing education and other supports. And then finally, I've been fortunate to be a telebehavioral health provider for over 20 years here in Kansas. I think over that time period, it's just been so exciting to work with families that otherwise would never be able to come into your office, and really use our best rapport and connection with families, as well as our best interventions. I think one thing from a provider hat that comes to mind is just looking across our many telebehavioral health disciplines. So, looking with our psychiatry and psychiatric nurse colleagues, our psychology and social work and therapy colleagues, Shane has articulated well the substance use disorder professionals. Also looking toward our applied behavioral health colleagues and the services they provide. And more broadly, looking at some of our health psychologists, I worked with our psycho-oncology group to give a presentation last Friday, and just kind of thinking about how can we use our overall telebehavioral health to meet those needs as well. And just again, just as you all have articulated, how can we be creative across the behavioral health expertise we have and provide those services and have it available for children, families, and adults across Kansas. I think with that is also the idea that's already been mentioned, just how do we keep consumer safety front and center? How do we enhance consumer education about telebehavioral health options? And also, how do you weigh the pros and cons as that family makes that choice? And then also as a a professor, just the discussion about supervision and ways that we can include trainees in our work. I really appreciated that. Thank you.
Okay, so this is Carly Houchin at KHI. Working group members want to open up the floor. Any questions for Dr. Nelson or any specific recommendations in her comment there that we'd like to be sure to pull out for further discussion?
Carly, Brenda. I think that we have to make sure that we're real careful in how we move forward with this so that we don't make telehealth so lucrative that we move away from the in-person care, because we still know that in this area of mental health that is still an important factor, to have that one-on-one contact. So I want to make sure that we're not going to get ourselves boxed in the future of getting away, having providers get away from having office visits.
Great, thank you for those comments, Representative Landwehr. Just to clarify, is there any of the specific recommendations we've discussed so far that we would like to modify in, I don't know, in consideration of that comment? Or more as a guiding comment there, Representative?
No, I think it's been made fairly clear.
Okay, thank you.
Yeah, Carly, this is Gary from KDADS, and I think in the beginning, my statement of what I thought would be good for telehealth in a modernized system is that we do have some way of looking at the use of telehealth as an adjunct to those in-person visits. Maybe that's through some sort of regulation or some sort of, stipulation on that. But I do think we do need to fund telehealth at a level that makes it usable for folks and accessible to people throughout Kansas. But I think there could be some guidelines in there about, when it's appropriate and the frequency of in-person visits versus telehealth.
Great, thank you for those comments, Gary.
Carly, this is Denise Sisman from Community Care. And two things I think that were mentioned, but I want to specifically draw our attention to, would be to include the opportunity to secure verbal consent with having written consent come later. And the other is to use HIPAA compliant platforms or telehealth mechanisms. So I know during the pandemic that was relaxed, and I think that was helpful, and it continues to be relaxed. But as we move forward and continue this as a more ongoing way to provide services, we would encourage the platforms and the technology to be HIPAA compliant.
May I comment on that, Carly?
Yeah, go ahead, Dr. Nelson.
That might be one area where our telehealth resource centers might have some additional resources, both in terms of the HIPAA compliance of the technology, as well as, again, vendor neutral questions to consider as you're looking to adapt technology.
Great, thank you. Final comments from working group members as to recommendations we should be sure to pull out of Dr. Nelson's comments.
This is Sandra with United. And one thing that I appreciated about Dr. Nelson's comments was the fact that we need to look across the spectrum of services that are provided under the umbrella of mental health. I know for us at the Managed Care Organization, finding service providers that provide services to the autism waiver and to the autism spectrum is extremely difficult. And I don't want to lose sight of that in the conversation around mental health, because sometimes they get set aside. So just making sure that we keep the whole spectrum in consideration.
Great, thank you, Sandra. And with that, in the interest of time, thank you, Dr. Nelson, for your comments. And I will turn to our last supplemental expert, which will be Sydney Mcclendon, who will be sharing some of the work that the CanCare Meaningful Measures Collaborative has done to engage with consumers around telehealth. Sydney?
Sure. Thanks, Carly, and good afternoon, everyone. As Carly mentioned, my name is Sydney Mcclendon. I'm an analyst at the Kansas Health Institute. So in addition to a lot of the working group members having seen me on these calls, helping to facilitate behind the scenes with Carly, we also help to facilitate the CanCare Meaningful Measures Collaborative, affectionately known as the Kmmc. And so just wanted to present a little bit of work that has been happening with that group, similar to what David mentioned previously around doing some provider surveying. We actually partnered in the last month or two with some of the CMHCs, some health clinics, and a consumer-run organization just to kind of do a pulse check on what consumer experiences, particularly CanCare consumer experiences, have been with telehealth since COVID-19 happened. So I was just going to present a high-level overview of some of the results that we found there, which are hot off the presses. I will say on the outset, the questions that consumers were responding to, there were 10. They focused on things like the type of technology that consumers were using during their visit, how easy it was to set up, and or any difficulties that they may have been experiencing during visits, like dropped internet connection, some of the things that have been discussed previously. Also asked about some satisfaction with telehealth that they may have experienced, how comfortable they felt sharing with their provider via telehealth relative to how comfortable they may have felt sharing during a in-person visit. Also had a question on there that was asking folks to think about how they may want to receive services following the pandemic. And then we had some open field questions at the end to ask about some general challenges or benefits that CanCare consumers who are receiving telehealth, anything that they may have experienced during those services. So I would direct you, if you're curious for more information, there's some background on the survey and one of the materials that Carly had sent out. That's titled Kmmc Consumer Engagement Report. And on the second page of that, just have some high-level findings from what we saw. Again, recognizing these were 700 CanCare consumers around the state, but it very much was a convenient sample, working with some of the clinics who were able to collect information. So I don't want to say off the outset that this is necessarily representative of the entire state, but really just a snapshot to understand what's been happening so far. In general, some of the things that I would highlight from the survey is just that the majority of folks, about 50%, indicated that they had used audio-only services at some point. 27% said they had used video, and then about another quarter indicated they had used a combination of both audio and video. Another thing that we noted is that a lot of folks, about 87%, indicated that it was very easy or easy to set up their telehealth services, kind of echoing, I think, some of what David had heard on the provider side as well. Excuse me. About 81% of respondents said that they rarely or never had technical difficulties during their sessions, and that would include things like dropped calls or bad internet connection. One thing to note, we weren't surveying folks who didn't receive behavioral health services via telehealth, so there may have been some other technology issues that folks who didn't receive services at all could have spoken to and aren't captured here. We did find that most of the respondents, about 70%, indicated that they were as comfortable sharing via telehealth, although we did have some 13% who were more comfortable in telehealth and 17% who were less comfortable relative to in-person services. And general satisfaction was high, with 50% of folks indicating they were very satisfied, and about 37% indicating general satisfaction. And then when asked about preferences for once COVID-19 ends, more than half indicated a preference for some kind of combination of telehealth and in-person visits moving forward. We also had about 15% who indicated that they were only interested in telehealth moving forward, which we found interesting. And then about a third who indicated a preference for all in person. So really kind of a mix in what folks are hoping for moving forward. This was a really quick overview. There's definitely more information in that document if folks are interested in taking a look. but want to be respectful of time too, because I know we only have about 15 minutes left in the session today. So I'm happy to answer additional questions here or otherwise as folks have them.
Great. So this is Carly Houchin at KHI. Thank you, Sydney, for that overview there of that work. Others on the call, questions for Sydney or recommendations that come to mind based on the information she shared? Okay, not hearing any. Thank you again, Sydney, for sharing that. So now the next item on our agenda, I will start a screen share here, but to kind of orient you as to where we are in the meeting's agenda and meeting materials. If you want to have the document open labeled telehealth barriers, I'm going to put that on the screen now, but this is the list of barriers that had been brainstormed across the 3 working groups at our first meetings. So we've come up with a number of recommendations today for the group to consider going forward based on the comments from the experts, the additional experts who have joined us today on these topics, but wanted to make sure we held space for the group to kind of zoom out and surface any additional recommendations that haven't come up in any of our other conversations. So what you should see on my screen here is a list of the barriers that working group members have had brainstormed previously. So the idea being that our recommendations should address these. I think a number of them have been discussed already, but want to pose the question to working group members, essentially what else? What other new recommendations should be on the table for this group to consider as we move into our prioritization meeting later this week? So a call here for other new recommendations. And if it's helpful, I can run through some of these barriers while folks are thinking. So the finance and go ahead, Gary.
This is Gary. So we're saying, other than the recommendations we came up with today, if there's something added from what we're seeing on this particular document. So in that sense, under policy and treatment, I think the expanding of telehealth services in the crisis arena, and maybe also in the care of foster care children who move from placement to placement, is certainly something we might want to address.
Thank you, Gary. So is the recommendation there just to expand telehealth services for those in crisis and for individuals in foster care, or is there a specific mechanism I should reference there?
I think there's, I'm seeing it as, yeah, I mean, the expansion of telehealth services in the crisis arena would need to allow, as we see in other states, the use of telehealth in with law enforcement or with crisis, mobile crisis type services. But I also think for foster children, it would be related to being able to maintain providers, whether that's therapists or med providers as they move around the state, if that's helpful.
Great, thank you. Any discussion from the working group on those 2 ideas? I'm attempting to capture some of them at the bottom of our screen as Gary's talking there.
Carly, this is Rachel Marsh with the Children's Alliance. I was going to mention that another issue that we had covered in a special committee on child welfare or foster care oversight this summer is the challenge that parents face trying to fulfill all their court orders when their children are in foster care. And that has to do with a lot of telemedicine it has to do with a lot of medical mental health and substance use appointments. So I might build on what Gary has said, and listening through this conversation, I began to think about a specific clarification in the Child in Need of Care Code, potentially, that would carve out that a parent in a child in need of care case is someone for whom we need to assume that there are those hardships to receiving care, so that we're trying to always balance. It sounds like we're trying to always balance whether it's a good quality service or whether a person really needs the in-person care. And I would just like to consider keeping a placeholder here for conversation about the unique needs of parents of children in foster care.
Thank you, Rachel. So I'm going to attempt to capture some of that on the screen, but please correct me. So something along the lines of consider unique needs of parents of children in the child welfare system, or maybe consider how these unique needs can be met via telehealth.
Right. I think for now that's probably all we can get to, but I think it's worth considering and pursuing moving forward.
Great, thank you. Comments from others? Running through the barrier list here, I'll try to flag things that we maybe haven't addressed, unless I'm mistaken. Something from the Policy and Treatment Working Group was maybe mobile competency evaluation services. There's a recommendation the group's interested to make around telehealth there. Age limits is a barrier that the System Capacity and Transformation Group came up with in terms of who should be utilizing telehealth services.
Yeah, Carly, this is Brenda. I think some of these, so an example would be looking at number 2 on the Finance and Sustainability Working Group, maintaining some of the temporary exemptions. We probably need to know, what are those exemptions? What's temporary on that? And then oh, there was something else and now I forgot it. I'm sorry. Go ahead. Someone else.
That's okay. So I'll maybe have a probing question there. So question to the group, to Representative Landwehr's comment related to the barrier that we wanted to address around maintaining some of the temporary exemptions that had been established under COVID. Are there any of those that we would like to address explicitly, or have we covered those in our previous conversations? So what temporary exemptions that have been made available under COVID is the group interested to reference directly, if any?
This is Representative Elizabeth Bishop, and I don't know if the issue of supervision via telehealth is part of that. I'm not sure exactly how much that was affected by some of the exemptions under COVID, but I do believe that's a personnel issue, mental health professionals issue that we might want to address. My suggestion would be to check with the BSRB, or perhaps among our experts here today, someone could offer some information about that.
Thank you, Representative Bishop. Only in the interest of time, I'll maybe flag that one for conversation at our meeting on Friday. The note that I have made related to that from in previous discussion earlier in the call was to utilize telehealth to allow for appropriate supervision hours across behavioral health disciplines, recognizing or making the note that we think this would require legislation and would certainly require coordination with BSRB to determine how that could be adopted across disciplines. Okay.
This is David Jordan. and this may build off of Gary's comment, but and it may have been inclusive of it, but I figure I'll pull it out anyways. I wonder if it's worth including, beyond just the crisis response, exploring virtual co-responder models for law enforcement to help aid and aid police departments and other law enforcement in responding to mental health in rural communities. I know there's some interesting cases, pilots in Missouri. And I also do wonder, and without having the benefit of fully look through this list, whether or not it's worth just pulling out, exploring the role that care coordination or other team members can play in better delivering mental health services, either through telehealth or as part of the mental health team. I know we've talked in the past that, what role can community health workers and peers play in this? And there's probably, beyond looking at the role that, of care coordinators, and I say that broadly, can play, it's just looking at covered services and reimbursement.
Thank you, David. Just to make sure I'm capturing that correctly, it would be something about exploring covered services and reimbursements related to care coordination, or I heard care coordination, case management, and CHWs in there. Should I reference one or the other, or all of the all three?
I think you could probably, for simplicity, you could probably just leave it at care coordination or care coordinators, and there's probably a finer point to put on this as you dig into it.
This is Gary from KDEDS, and to your point, David, we've seen not only in Missouri, but also in Oklahoma, where they're using telehealth in conjunction with co-responders to access crisis services for mental health. And I'm sure in other states too, but those two I've seen myself.
And Carly, this is Kyle Kessler. And I was going to add, kind of going back to what Chairwoman Landwehr was saying, and also Representative Bishop, I think that that's something that we need to see further into the future post-COVID, as we look at a modernized mental health system. This pandemic and obvious other experiences will have created an awful lot of PTSD. And so I think that to be able to use telehealth as a mechanism for more mobile crisis response services could be a significant impact for the system. And I know Missouri and Iowa, other states, which were very, very quick to flip the switch to telehealth services, they're already having the conversation about what services to keep in terms of the whether it's psychosocial group or things that will work. Obviously, the preference, especially in non-rural or frontier areas, is probably to go to more in-person services. But for some people, the anxiety relating to getting out or potentially being exposed to illness is going to last well beyond the pandemic. And the challenges relating to location and technology in rural and urban areas will still be there. So that's kind of our thought process behind wanting to keep a lot of the current processes in place as long as CMS lets us, whether that's telephonic use or keeping some of the billing the same, at least in the near term. As it relates to the BSRB and telesupervision, that would also be a significant thing for us in terms of our workforce. I mean, poor David Fye, just when he thought he'd gotten rid of us, we're pulling him back in. But I think that that's something that would be a good conversation with the BSRB to see around. And Shane mentioned that there are some of the disciplines that probably look at this a little more closely and fondly than others, but it'd be nice to have some uniformity across them. That's what I have. Thanks.
Very good.
Carly, to tie on to that, I think it's important for us to understand that, that we understand the benefits of telehealth, but we also need to make sure it's not replacing, when it's not necessary, the in-person. That's going to be a huge deal in all of this. I think another thing that I kind of thought about is, what are the issues of these sessions being recorded by someone? And I'm asking the professionals because I'm not one of them.
May I comment on that?
Yes.
Hi, this is Shauna Wright with the Center for Telemedicine. And in general, we don't record our in-person sessions, right? And so there should be very few exemptions of when we would recommend to record a session. And again, that's a part of informed consent for any client or patient that we reach. So we should not only should we not be recording sessions unless we're under supervision and the client or their guardian has been brought into that, we should also be advising them not to record their sessions. Sometimes providers think they're protected against a patient or a client recording a session because they may have all of the Zoom controls. I don't know if any of you have seen a teenager's phone and how easy it is for them to set that up and make a video that they share with the world, but we need to be educating our consumers about the risks. So I'm glad that you brought that up. I think that comes in with our basic standards of care, that unless we have a specific need, reason, and purpose for recording that the client or patient has been informed of, we don't record that data, particularly with mental health services.
Well, and my concern was not so much the professional recording, but it was the client recording.
And so
how do we address that?
Right, and that comes along with patient education and informed consent and helping them understand that if that's something that happens, not only the risks of doing that and heaven forbid broadcasting that to others, but then that as a part of our assessment of when telehealth is appropriate or not appropriate, if that boundary gets broken, then we may say, wow, we can't continue to provide telehealth services based on this. So it becomes part of that provider-patient agreement and the education process.
In our group services, our patients all sign a confidentiality statement that says what's said here happens here, stays here. And they could go out and tell everyone exactly what happened and say, John Smith from the restaurant you go to in town said this in treatment. Now, I don't see that happening. Those things could happen with in-person services, could happen with telehealth. I don't see it as likely if someone's benefiting from a health service that they value. People could record things in group now because we allow them to have their phones on them versus collecting their phones and having the liability of a $1,000 phone getting broken during that process, or like ensuring everyone leaves it in their car because things happen. So there's still some avenues where that could occur in person, but we watch out for those things currently and we do so in telehealth.
Great. So this is Carly Houchin at KHI. I'm going to jump in there only in the interest of time. I truly hate to cut off just some really rich conversation today. So I want to thank working group members for joining this subgroup and being part of the discussion this morning. Also want to thank all of the experts who've lent us their expertise related to the topic of telehealth. Likely you all should be aware, you should have calendar appointments from me. This conversation will continue on Friday. On Friday, we will be translating the recommendations that have been brainstormed based on all of the information we heard today. We will be taking those recommendations and be trying to get to our highest priority to put forward for the special committee to consider at their December 10th meeting. So look for more information from me ahead of that meeting. I'm going to try and get us up, get us ready to make that decision as efficiently as possible. So we'll try to get supporting documents out to you as soon as is feasible. But if there are no last comments or questions today, I will go ahead and adjourn this group until Friday for our next meeting. Okay, bye everyone.